Today we're going to discuss different technologies, different methods that exist that we can use to ease some procedures in the process of taking impressions, in the process of having interocclusal relations, in different types of processes that we do day to day in our clinic, but are much simpler with the technology of the cadcam that sometimes we don't even think about them this way. For example, in here you can see we took relations, interocclusal relations, using the cadcam technology. Now, what the cadcam technology gives us that we didn't have previously? First of all, we're having here scan abutments. Doesn't matter right now on what type of parts we have the scan abutments, but we want to have these kind of abutments on the upper jaw, and we want to have them in relation to the lower jaw. So if it was a traditional method, what we would do, we would take wax, we would know the height, we would know the central line, we would know different elements using wax. But if you want to scan, if you want to use the cadcam advantages, you can't use wax. So what we're using is we're taking composite material, we lay the composite material on the buccal side of the scan abutments. So what you have is the same scan abutments, but you have a rim of composite in the buccal part. The composite material is in relations to the lower jaw, so you have the indentations of the lower teeth, you have everything you need, you scan it, and you can place the clean jaw on top of the jaw with the composite material. So you're using cadcam technologies, you're using intraoral scanner, and you have the perfect occlusion, because in here you know where the central line is supposed to be. You can mark the canine lines, you can do everything. You can see the height of the lip line, of the smile line, of the gingiva line. You know the height that's supposed to be of the antagonist that you want to design. And then you just take this scan and relate on top of this one.
I look at all these images and I think it doesn't look like it's straightforward, intuitive for a doctor to take an intraoral scanner and be able to perform this procedure.
Exactly. It's gonna take time. It takes some chair time because you need to build this composite rim onto the scan abutments. And it takes a lot of time instead of just taking wax and sending it to the laboratory. But on the other hand, you have a consistent interocclusal relations every time the patient opens and closes his mouth. You have reliable information because what you see here is what the technician would get. You know that this is the occlusion. When you take the occlusion with wax, the technician can make anything he wants. If he thinks it fits, if he thinks it fits like that or like this, you don't know exactly what the occlusion will be, and you have much more deviations in the end result. In here, what you see is what you get. You see this occlusion. If you think this occlusion is right, you can proceed, you can send it to the technician. But if you think you have here a problem, that probably you did something wrong. When you're using traditional methods in taking interocclusal relations, you don't know what the end result would be because it switches so many hands. You take the impression, you need to send it to the technician. It can deform in the process of the delivery. The technician needs to take the wax, to take two models, to put them one on top of the another. If it deformed or not, or didn't fit, didn't sit till the end, you don't know what you'll get. And the next time when you check it, you have already crowns. You can't be sure that the end result, the end crowns, will be similar to the relations you got. In here, everything is in your hands. You can see it right away, and you know if what you got is the same that's in the mouth.
I want to return to the question that we talked about in the first part. We receive feedbacks from dentists about this intraoral scanner. Some of them say that they cannot scan some of the abutments. Some of them say that they have some sort of deviation or problem with it. What do you think?
If, as a first case, you'll try to scan 9 implants without any teeth, without any hard tissues, it's as hard as taking impressions, traditional method, on 9 implants on the first time. You need to have some learning curve. You need to start with something small and learn how it works, because you have some things you can do to ease the work. With time, you understand that you need to have a dry gingiva for the gingiva to scan better. The upper jaw, much easier to scan because of the hard palate that you have. In the lower jaw, you have the tongue and you have much smaller jaw, and in many times the gingiva is moving. So for the scanner, it's very hard to scan. In this case, for example, when you take impressions on the lower jaw, the only thing that connects the scan abutments is the composite rim, because your gingiva is moving. The scanner doesn't know how to scan when the gingiva each time in a different place. Mm-hmm. So in the first place, we just put a composite rim, then we scan the composite with the scan abutments, and we have something hard, something constant. To that composite rim, we scan everything else. We scan the gingiva and we scan the scan abutments. Mm-hmm. So we'll get in one scan all the information. The problem is you won't have the gingiva quite good.
So as everything else in life, it just takes practice.
Yeah,
you need to start small.
You need to start small. You need to have a little bit of practice with the small works. You need to see where you have problems, mm-hmm. and you need to know how to see those problems, because it's not visible right away, and you can scan whole jaws and everything will work when you have enough experience.